Welcome to the first of the lecture in our series, 5 lectures we have on de-implementation, and we're going to start by looking at some of the recommendations in our national guidelines, in particular the UK and Ireland guidelines, which are the most recent, published in 2023. I'm Annie McCluskey. I'm an occupational therapist and a member of the StrokeEd collaboration here in Australia. I'm in the eastern part of Australia, and I pay my respects to the traditional custodians of the lands on which I'm meeting here on the central coast of New South Wales, and pay my respects to elders past and present. We are recording this session, and it will be available on our library within probably a couple of days, along with other lecture recordings. So you can go to the resources section of our website for that. If you have any questions or comments, use the Q&A section at the bottom of the screen. Please don't put up your virtual hand because I'll ignore it. We just don't have the capacity to answer questions live. So type your question in the Q&A, and then I'll save them up and ask Louise and Sarah any questions or pass on any comments you might have. There's no certificates being issued for people attending. And we also aren't providing any handouts for these free lectures. So just thought you might like to know that in advance. We have with us tonight or today Sarah Tyson, who is from the University of Manchester in the UK. And Sarah was actively involved in the stroke guidelines published last year, leading the motor recovery group. She's also been very active in writing about the research on Bobath, and was a co-author on 2 of the systematic reviews with the StrokeEd collaboration members. So we'll come back to that in one of the subsequent lectures. Louise Clark is an occupational therapist and is based at the Dorset NHS Trust in the southern part of England. She's an associate director of the Sentinel Stroke National Audit Programme, which leads the guideline updates in the United Kingdom and Ireland. And she's the overall editor, a huge job, which must have taken many, many hours and months of work. Louise particularly led the rehabilitation section, which we're mainly interested in for quite a lot of the lectures that we're looking at. So as I said, this is the first of 5 lectures. Next Monday, we have another content area on splinting, hand splinting. We have a session on Bobath therapy and what the research tells us about that. And on the 20th of February, we have Jake McMahon, who's going to be talking about what de-implementation is. And for those of you who don't know, it's really trying to change practice, and rather than introducing a particular intervention which has been shown to be effective, what we're hoping to do is to change the practice of individual therapists and services to stop particular treatments which have been shown to be what's called low value. They're not of any benefit to patients, and there may be another treatment which is more helpful and more beneficial. So we don't want to waste important resources, scarce resources, and therapy time by using interventions which are ineffective and of no benefit. So that's the history or the background to this series of lectures. And it'll run for no longer than an hour, we expect. And there'll be lots of opportunities for questions and answers during and towards the end. So I'll hand over now to Sarah and Louise.
Good morning, everybody. Thank you so much for having us. Just apologies in advance in case this happens, but we may well have interruption from children at my end, chickens at Sarah's end, and cockatoos at Annie's end. So we'll deal with that as and when they come up. It's breakfast time here. So thank you. I think we'll have about 40 minutes probably of us presenting today, with a break in between for questions, and then some time at the end for questions. So I hope that's okay. So just in terms of what I'm going to be covering, I'm just going to be giving an overview of the chapter really and the process that we followed. And then Sarah's going to be going into more detail around some of the nuts and bolts and particular recommendations of interest in the motor recovery section that she led. Let's see if I can get my slides to move. Okay, so just in terms of how the guideline happens, just wanted to share a little bit about the process of how we went about this partial update. So just a reminder for people that this UK and Ireland guideline covers all 5 nations for the first time in the UK, which is great, with collaboration with the Scottish guideline group SIGN, the Northern Irish group, the Welsh group, and Ireland, Republic of Ireland as well. So that's a change for us. It's a partial rewrite for a number of reasons, one being financial reasons, and secondly, just in the interest of time. So we normally publish an updated guideline every 4 years, and we were out of time with that, with the previous edition being 2016, obviously derailed somewhat by COVID. The decision was made that we would just update the areas where there had been the biggest shift in evidence or practice, and that still was an 18-month process. So you will see as we move forward that not every area of the guideline was updated, with some aspects of the 2016 guideline staying almost untouched. There were some other changes this time, so you may have noticed that we've purposely not named any specific assessment tools or measures. Instead, we recommend the use of validated and structured tools to future-proof the guideline in the event of any new measures being published ahead of the next edition. And lastly, we've tried to be as non-profession specific in our recommendations. So you'll see that there are very few recommendations that say a physiotherapist must do this, a neuropsychologist must do this. Instead, we have recommended commonly throughout that the tasks are undertaken by someone with appropriate knowledge and skills in line with more of a competency-based integrated MDT workforce. So this is the process that we went through. The development of the scope was led by the Intercollegiate Stroke Working Party, and that identified 59 areas where there had been the biggest shift in evidence, as I've mentioned. 29 of those 59 were in our chapter in rehab and recovery. So that just goes to show the huge change in rehabilitation, which is great. The process there was that there were PICO questions written for each of those 59 questions, and a fantastic team that sat behind us did the literature reviews. The abstracts then came to myself as the editor for the chapter and the topic group leads, of which Sarah was one, and we went through over 3,000 abstracts for our questions. The job of us two, as we were going through that, was to sift through those and ensure that we were looking at the questions of the articles of most relevance and of the highest quality in terms of methodology. What happens next is that 676 of those papers were then reviewed in full, and we had a great team of multi-professional team that sat in each of the topic groups. Every paper was reviewed by 2 reviewers, and they appraised the evidence and completed an evidence table, which is all available. You can see that appraisal of those papers in the appendix of the guideline if you're interested in that, and brought that then to a topic group meeting where those the findings from that paper was weighed up to see whether there would be any change to the existing recommendations. So that's the process there. For particular questions, there were some health economic reviews done in the background, but that wasn't done for every question. And then at the end, once we had written our draft, it went out to external peer review and public consultation across more than 45 organisations. So this is an overview of our chapter. So this is rehabilitation and recovery. And in dark print here, this shows each of the areas where we did have questions. So these are the areas that were updated in our chapter. The numbers next to these represent how many questions there were in that specific area. So for example, upper limb, we had 8 specific questions. For hydration and nutrition, we had 5 particular questions that needed to be answered. So a real spread of what was covered in this partial update, but like we say, not everything this time. The areas that have got a C in brackets next to them were areas of consensus, and I'll explain about that consensus process later. And the areas where there is a U next to it, and I think splinting should be one of those, I'm just trying to see where that is on the list, was an area where we didn't specifically review the evidence, but we updated it in light of things that we found in the questions that we did review. So if there was something that then made the 2016 recommendation fall out in terms of relevance, then we did update that, but that was a slightly different process. So these are the topic groups, and Sarah, I'm sorry, I've stole this slide from you, so thank you. These are the various topic groups. These were all led by different people. Sarah, as we've said, led the motor recovery section, and this is a bit of an idea about what went in each of those. And some of them might seem like a funny mix, so vision and upper limb don't typically go together, but that was just around division of labour, really. And nutrition, hydration, language and depression sat together to start off with. Some of these things did move around. The broader issues in rehab section, which was led by Professor Avril Drummond, who I'm sure many of you will know, were mainly the areas that we felt that were too important not to comment on. And these were the areas predominantly where we had consensus process. So these are the areas that were entirely new in our chapter. With psychological care, you can see there were 3 particular topics that were entirely new, with particular interest around apathy. That was a really interesting one to chair, actually, with support of Professor Shirley Thomas. So these are entirely new areas of practice, which some of which we'll talk about in just a second. I just wanted to focus a second on rehabilitation potential. I think we feel particularly proud of this being in. It feels really, really important. And this is right up front in the chapter, which is exactly where it should be. It's crucially important for people with stroke, and it frames a lot of how we think as professionals and also how we run our services. So these recommendations are that we no longer use the term no rehab potential, and that people should be considered to have potential for recovery, adjustments and support needs any time after their stroke, and be able to re-access services on that basis. This moves us away from somebody only having functional goals that they might meet and broadening out the scope of rehabilitation, which covers the sorts of things that are on the slide here: psychological wellbeing, adjustment, education, helping people to understand what's happened to them, moving the rehabilitation space much more into social participation and leisure. We had services over many years with ESD, early support to discharge in the UK, that a lot of those stopped at about 6 weeks. And obviously there's a lot of work to do in 6 weeks, and that doesn't often move into that sort of leisure and participation space, where now we have the licence and the service structure to do that. And then the other important point was around managing care needs. That quite often sat in social care, which is often separate to our health services, and recognising that actually for long-term support of our patients, training the carers is really, really important, and especially given that we might be expecting them to assist with some of the rehabilitation. So this opens a lot up in terms of our services and our requirements, but it does fall in line with our new-ish, so 2022 published NHS England specification for our stroke services.
Louise, can I just ask you a question that's come from one of the audience about the rehab potential? Somebody's asking if a person's not changing, for example, with their sitting balance after a couple of weeks, there's no observable change, and they're likely to be going to a care home. What does this mean for somebody in the acute stroke units or in an inpatient rehab unit?
Yeah, sure. So it's not about saying that we should keep people in hospital forever, not at all. It's about moving people along the pathway to the place that their care can best be met. What we're saying here, though, is that you wouldn't deny them access to services later on. So there may well be work that we need to do with the carers in that care home, for example, around positioning, helping them to understand that person's communication needs, cognitive needs, helping the person's adjustment around, unfortunately, things aren't moving forward at the moment, but we might be able to see things later, or we might not. So that education and adjustment, and then helping that person whose life has fundamentally changed still to be able to function in their new way of being. So you wouldn't keep beasting, for want of a better word, sitting balance if there was no movement, but you would work on that, landing and contextualizing that stroke for that person in their life. You may not keep them open to stroke services for indefinitely. They might be discharged from your team, but have a route back in for review or if things change.
Thanks. Yeah.
Okay. So just another couple of areas of interest before Sarah gets into the meaty stuff. So We also have in our guideline staffing recommendations. These are not done through an evidence process in the same way. So this is listed as being consensus. This is based on our national audit and the well-performing services in our across the UK. And this did see an uplift from the previous version. Our staffing previously used to be based on 5-day-a-week services. So this uplift is just simple maths, dividing the week by 7 and adding an extra 2 days worth of resource in. So this is for inpatients. The big requirement for this is because our initial assessment by each profession is moving to a 24-hour standard now, whereas previously that used to be 72 hours to allow for those weekends. So we will see a change in our national audit to reflect that. And then for the first time, we had staffing recommendations for the community services. This is slightly more evidence-based in terms of it being based on the work of Dr. Rebecca Fisher, who's led a lot of the work around early supported discharge in the UK, and falls in line with, our national NHS England service model for the community. Just for transparency, many of our services don't reach anywhere near these levels yet. These are something where we don't have all of the workforce to do this yet, but we will be measuring this and hopefully seeing change over time. And there's workforce pipeline work being done in the UK to try and address this. I won't talk about this too much because Sarah will talk about this in a second, but one of the biggies obviously is around moving our therapy recommendations from 45 minutes of each profession where the person is able to tolerate that to 3 hours of motor therapy. There is no getting away that this is a huge jump for us in the UK, especially given that graph in the middle there that shows that less than 40% of the time, and actually closer to 30% of the time, we were only just meeting our 45-minute standards across each of the professions. So we know that we've got a lot of work to do, but we'll talk a little bit more about why that threshold was changed. I think the other thing to say is it's really important to remember that this isn't for everybody. There will be people who can't tolerate these sorts of levels of intensity, and this is particularly for people with motor recovery goals. Sarah will talk about this more later. But what we're hoping to see is a progressive move over time as we all innovate and share ideas and move practice forward together over the next few years. But a big recommendation. Again, I won't dwell on this, but I think we need to remember that this is likely to be for people with those higher levels of activation. It's probably fair to say that we don't do enough at the moment around understanding people's levels of activation, doing the work with people to understand where they are about their understanding around neuroplasticity, their stroke, their acceptance. We need to understand them in their context of their psychological position and their motivation and activation before we start throwing 3 hours of therapy at people. This isn't just about drilling motor recovery. There is a broader context that we need to be mindful of here as well. And of course, as ever, all of the recommendations should be individualised and negotiated with the person with stroke according to their preferences and goals. So how do we get to such a recommendation? And this is just a look at some of the upper limb evidence, and this is looking at the systematic reviews and meta-analyses. And you'll see that this is just the work that was done between 2016, the last edition, and our evidence reviews over 2021, 2022. And this shows that the number of good, high-quality studies and patient numbers that underpinned just the movement in upper limb. And you can really see that this is a testament to our research colleagues and all of our research active teams that there has been such a big jump in the evidence behind upper limb rehabilitation, just as an example here, but around a lot of the other areas that we covered as well. So to carry on with the upper limb table here, when you look at the evidence that underpins that research that we were reviewing, these are the sorts of levels of therapy that we were talking about for each one of those interventions. This is taken from the research protocols, and we're talking about there being various interventions that would be relevant, particularly potentially for the same patient. One patient might be relevant for more than one of these, and actually we're looking at really high numbers of minutes just for these interventions. And then we need to imagine that we've also got the same sorts of numbers around walking, gait, balance, as well as everything else that we do as part of stroke rehabilitation. So it became really clear that 45 minutes wasn't going to cut it if we were wanting to address, a wealth of somebody's difficulties and give them the best chance of recovery. So my last slide on this, we were really clear that we wanted to avoid people either choosing one intervention and delivering it at a level of intensity that might be effective when somebody might benefit from a range of interventions, which is likely. We also wanted to avoid people delivering 3 or 4 different interventions, but trying to squeeze that into 45 minutes and actually delivering all of those 3 or 4 interventions at a non-optimal dose, because that's just not going to be clinically effective. So that's the background really that moved us from that 45 minutes across the professions to 3 hours. But I'm sure that Sarah will tell us more about that. So I'm going to stop there and see if there's any questions, if that's okay, and then open the floor to Sarah.
Yes, there are a couple of questions that I think probably are best for you to talk to, Louise. The first one is about the abbreviated mental test score, the AMTS, which we're not familiar with here in Australia. But what's your thought about the AMTS for screening people's cognitive function? I know in Australia we don't have any commentary in our guidelines about outcome measures or screening tools.
Yeah, so my personal view is that it doesn't tell us enough, that we standardly in practice would be using something like the MOCA or the OCS, Oxford Cognitive Screen. I think we need to be ensuring that we look across all of the different domains of cognition, and particularly if you're doing that on a hyperacute stroke unit, something like the AMTS doesn't show those higher level deficits. And if you were making a decision about whether somebody was going to move out into the community quite quickly, you're really at risk of missing some of those higher level impairments, which would have, big impact on somebody's ability in terms of return to work, driving, road crossing, money management, those sorts of things. So we would always do a more comprehensive screen, still something that takes about 30 minutes, 40 minutes, nothing more detailed than that. So still very much classed as a screen rather than assessment, but we would be using something like the MOCA or the OCS. You may have seen that there are recommendations for the first time about screening for delirium, and just making sure that we are not doing cognitive assessments too early when actually there may well be a delirium present. Again, we didn't review the evidence to be able to specifically name any tools.
Okay, thanks. There's another question about mood disorders and screening for mood disorders, the PHQ, which is the, what does that stand for?
Patient Health Questionnaire.
Yeah.
That's for depression.
Asks people about their feelings over the last 2 weeks. And so the question is whether that tool should be used on the first day of admission or the first day of stroke, or whether you wait 2 weeks.
So interesting, we've just had some conversations yesterday in our local service exactly about this. When somebody first comes into hospital, they have been thrown through a tumble dryer, really, before you first meet them. So they'll have come in by ambulance, in a scanner, distressed, wanting to understand what's going on with them. Doing a mood assessment on day 1 isn't really appropriate. Our recommendations say that they need to be done before discharge. So within that first period of being in hospital. We actually had some discussions about potentially using a distress thermometer in that first instance. And we do ask about previous mood issues on that first meeting in our initial assessment, but we would then go on to use measures like PHQ-9, GAD-7, the BASDEC, the HADS, those sorts of things during their stay, but certainly not in that first couple of days. We need to let the dust settle.
Yeah, and I think the amount of time you have for rehabilitation and for any intervention is so limited that the more time you spend on assessments and screening, it takes time away from the interventions.
Absolutely. So we do have a standard that 100% of people are screened for mood before they're discharged in the UK, and we mostly hit that, but that certainly isn't done up front. And like you say, Annie, we need to get going early on, don't we? Not spend lots of time looking at pieces of paper.
Yeah. I might ask the other question that's here before Sarah takes over. It's about orthoptic assessment for people who've got visual problems. Has anything been added to the stroke guidelines, and was there any commentary on rehabilitation for visual problems by non-eye health professionals such as OTs and PTs?
Yep, so vision was one of the areas that did have some new work, which is great. There were staffing recommendations for orthoptists for the first time, and a requirement for them to be a core member of the MDT in every stroke service. That's great. We have a recommendation that everybody should be screened using a standardised visual tool. That doesn't necessarily have to be a validated visual tool, although we do have the Visa here from the University of Liverpool, which is a great resource. What we are asking for is that there is a standard way that each member of your team would do that screen. So, you know, not that everybody does something different, but you've got a locally agreed pathway if you're not using the national one that's been agreed with your orthoptist of how you screen and how you refer, but everybody should be screened during their admission. We do that within the first 3 days, and most units would do that as part of their initial assessment. In terms of rehabilitation, unfortunately, those questions weren't part of the scope. It was really looking at the screening and the staffing numbers this time. There are some recommendations from 2016 around things like scanning training and those sorts of things, but unfortunately, that wasn't an area that we were able to review in detail this time. Again, though, we would say the same as we do with all of our recommendations, that it doesn't have to be a particular profession. It needs to be somebody with the relevant skills, competencies, training. So absolutely, occupational therapists and others would be involved in some of that work.
Thank you. Over to you now, Sarah.
Thank you. Hello, everyone. I thought I'd just start with having a quick look at the method. I know Louise has spoken to this, but I was asked to compare and contrast with the UK and Ireland guidelines and the Australian, New Zealand ones. And my understanding is that the Australian and New Zealand, forgive me, New Zealand, used their guidelines were based on the grade methodology, which is how when you essentially categorize the level of evidence from terrific to not so good really, and then make the recommendations solely based on that. We haven't used that because we felt it gave an excess emphasis on phase 3 randomized controlled trials, and which tend to obviously be focused on single interventions, and there's more to stroke care than that. So we use best evidence, which enables you to, even if you haven't got copper bottomed, stage level 1 phase 3 RCT evidence, you can still say this is the best that, this is what we know, this is the best recommendations we can make. And we wanted, particularly in the rehab, or in the motor rehab, it's very clear now the evidence of what we should be doing. And the evidence is very strong. So we, rather than just saying you should be doing X and Y, we wanted to look as much as possible at the evidence on how to deliver and implement the interventions that we were recommending. And as part of that, we included qualitative evidence, as well as the quantitative, the RCT level evidence. So that we particularly wanted to hear the patient's voice, as the current jargon goes, but we wanted to be able to look at the full breadth of evidence that was relevant. As Louise mentioned, the recommendations are arranged according to the patient's problems, their impairments and activity limitations, rather than recommendations for any specific professions. And as part of the whole thing about implementation, we included recommendations for the whole of stroke care services. So there are recommendations for managers and commissioners, not just what therapists or the kind of direct contact healthcare professionals should do. And I know this sounds terrifically geeky, but the guidelines, they're quite a good read, really. We did include quite a bit of explanatory information and background with information about why we made the recommendations and to put them in context. So there is quite a bit of extra information beyond just the recommendations about what should be done. Have the next slide, please. Come over all Chris Whitty. So the way in which the recommendations are worded in these guidelines are, when it's a strong recommendation because there's strong evidence, then we say X or Y should be offered, should be provided. So we've got the big should word. And that not only indicates that there's high quality evidence, but of course that the evidence is positive for this intervention. You can have high quality evidence that something isn't effective, which we'll come on to later. So we want, it also means that it's effective, it's likely, it'll be beneficial, there's a low risk of there being any harms or undue burden in delivering this. And then we have more moderate or evidence. We kind of start putting some wiggle words in there. So we say things should be considered or even may be considered if it's even weaker evidence. So if the evidence isn't as it could be, or that there's a risk of adverse events, or that it may not be acceptable for patients might not find it acceptable, or it may be very difficult to deliver. So that's just to put the recommendations into context and what's behind it. Thank you. And so these are the questions that we looked at regarding, I guess, the main. Oh, these are the original questions, aren't they? Sorry, we haven't. Sorry. That's it. Next one. Thank you. So I'll talk mainly about these two these are the biggies, if you like, the big recommendations, which were for people with motor goals. So not everybody who comes into a stroke service, but people who are candidates for physical rehab and have motor recovery goals. So this doesn't include speech and language therapy. But they should be receiving 3 hours of therapy a day. That's OT and physio. Not the previous guidelines said each relevant profession. But we're looking. One of the things that needs to be done is moving to a more interdisciplinary approach to rehab. So it's multidisciplinary care, and also patients should be supported to be active for up to 6 hours a day. And then the kind of a big factor behind that recommendation is that there's very, very strong evidence now that exercise and repetitive task practice is the most effective approach for motor rehab and after stroke. And so that should be used principally in preference to other therapies, including BOBAth. Have a next slide, please.
Can I just ask you to stay on that slide for a minute and answer a couple of questions? Somebody was asking about when somebody leaves hospital. So what you've got on the slide there on the left about amount of time, and the same in the Australian New Zealand guidelines, it's silent on whether this refers to inpatients or outpatients or community. And so I generally say to people, if it doesn't state that, it applies to everybody, whether they're in hospital or whether they're at home. So what are the times?
Yes, it's all settings.
Yeah, all settings, that's what I thought. And the other question is related to the right-hand box there, BOBAth. The recommendations about acute stroke rehabilitation, or is it general across all areas?
No, it's all settings.
Yeah. All
settings, all stage of stroke, all severity of stroke, all age of stroke patients. It's everyone.
And from memory in the trials, because both Sarah and I were involved in the systematic reviews that will be discussed on the 28th of February about ball bath, the studies, there were some involving people in the early stages and some in the rehabilitation stages of their stroke.
Yeah, and some in the chronic later stages as well.
Okay.
Okay, can we move on?
Mm-hmm.
So I'm not going to go into great detail about the bow bath thing. I'm happy to take questions if people want to do so. But the recommendation was based, as Annie had mentioned, on 2 big reviews and meta-analyses. In fact, just about, I think, yeah, all of our recommendations were based on level in the what would be called level 1 evidence in the grade recommendations of so we've got strong evidence from high quality systematic reviews and meta-analysis, and these were 2 that we did specifically looking at bow bath therapy that showed that task specific practice and exercise were more effective. So why would you carry on doing something? And I mean, I know a lot of people have stopped doing it already, but why would you do something when you know that it's less effective than something that's more effective? You know, do what works best. So if we move on to the next slide, we'll concentrate on what we should be doing rather than what we shouldn't. So as I said, the 3 hours of therapy and the 6 hours of activity, that applies to everybody, all settings. And as I said, our recommendations include all levels of the stroke care services, and we have a recommendation that everybody needs to drive improvements. And this, as Louise alluded, for some services, reaching this level of therapy and activity does mean a very big change in the way they operate. And you can't deliver in some cases, massive increases in the amount of therapy by doing the same thing in much the same way. You may well be looking at a fairly major rethink and reorganisation into how rehab is delivered. And so that change of culture and the processes needs to be driven at every level. To be honest, look, I've been involved in some of the key studies that were kind of behind this this recommendation as well. And although it does involve people at all levels, the services that were really affecting rehabilitation all have a very strong kind of local lead at a therapy lead, that kind of level. It's the local on the face leadership that really makes the huge difference. But also connected, not letting the commissioners are people who are outside the trust, who make decisions about what should and shouldn't be funded in the UK, just for those of you who are outside the UK. So we've tried to make sure that we don't let them off the hook, and they realise that they do have to fund services properly. That they need to make sure the patients have access to adequate space and equipment in order to be able to deliver these recommendations. Next slide, please. So what does this 3 hours of therapy include? I think it would be very difficult, well, certainly be very boring to do 3 hours of one-to-one, the traditional, if you like, one-to-one hands-on therapy. So there's a need to really, well, for some services, this will involve thinking outside the box. Some services are doing all this already in the UK as well as in other countries. But there's you need to think more broadly about what therapy is and how it's delivered, so that the 3 hours will include things like groups, whether that's different types of activity groups and exercise groups. An open gym is when you have an area which is set up with equipment and facilities for the patients to come in. There would be a therapist present and to offer semi-supervised exercise, and obviously maintain safety, but enable the patient to be working on their own program within that. So that would, circuit training, if you like, is classic way in which that's delivered. And it also involves other types of semi-supervised practice, and also organising independent practice. So the patient's actually practicing their functional tasks or doing their exercises independently outside the therapy time or outside the direct supervision of a therapist. That's part of the 6 hours of activity, but not part of the therapy. But the time you take organising the independent practice, because these things don't just happen, they're not, you know, they don't come out of the ether. So the time spent organising the practice would count as the 3 hours of therapy. And also patient education would count as that therapy as well. So the next slide is, whenever we talk about this, there's always somewhere, and I expect somebody's fingers are itching over the keyboard saying, my patients can't possibly do this. And it's a truth universally known that pretty much every service feels that their patients are much more severe and much more complex than other services. And I have to say, when you look at the epidemiological data and the national audit data, people who have strokes and the types of strokes they have and the severity of the strokes they have and the way that it affects them is pretty much the same, certainly across the developed world. So if you feel your patients won't be able to do 3 hours a day, and there are services in the UK that are delivering this and have been for quite a long time, and this was pretty standard stuff back in the day when I was leading a stroke therapy service in a rehab unit. It's a long time ago now, but this isn't quite as revolutionary as some people think it is. In other countries, it's been standard practice for people to be active for 6 hours a day and to be having 3 hours a day for a very long time. So it is possible. I'm not saying that it's not a challenge, and it will involve a lot of change for some services, but it is possible. So, but if you feel your patient isn't able to do this, then you need to think about why not. And to be honest, have quite an honest think about, are those limitations the patients, or are they actually the professionals? Are they because you don't have the confidence to know how to do it, or you feel that you don't have the resources? And if you don't have the resources, what are you going to do about getting them or using the resources that you do have more effectively? But if it is that the patient isn't able to tolerate 3 hours of therapy, then that's fine. It doesn't mean that if they can't do 3 hours, that 2 hours is no good. That's still a lot more than most people are getting or many people are getting at the moment. So you need to devise strategies to find out what the patient can do and to enable them to do as much as they possibly can. So this isn't a black and white thing. It's not 3 hours or nothing. If they can't manage 3 hours, 2.5 hours is just fine. And this is also at least. So if people are doing more than that, over 3 hours is fine as well. But this isn't something you can, we're not giving you the wiggle out of just saying, oh, the patients can't do it. The patients really can't do it, then find out what they can do and enable them to do as much as they can. Next slide, please. Okay, I was just going to say that in the guidelines, there are also recommendations about what therapists or services overall need to do to ensure patients adhere to exercise. Obviously, exercise and task-specific practice is only effective if people do it. And as I said, that doesn't just happen organically. It has to be organised and prepared. And there's a lot of evidence now about how to maximise adherence to exercise. So as well as the activity recommendations, there was that for the exercise and task-specific practice. And in the guidelines, there's a whole new section on weakness and cardiorespiratory fitness. And the recommendation is that people should be offered cardiorespiratory or aerobic fitness training or mixed aerobic and strength training, once they're medically stable, obviously. We're not going to, we're not suggesting people are dragged out off from their thrombolysis drip and put on a treadmill or whatever. But once they're medically stable, they should be offered exercise and task-specific practice, and that's regardless of their age. Even very, very elderly people can exercise. The time since stroke, the evidence is effective, just as effective for chronic people in the chronic stages as the acute, though the degree of response tends to be less, and the severity of impairment. So people who are severely impaired, who may have very little or no movement, then obviously the exercise they do has to be adapted, but it can be adapted so that they can exercise. And again, as Louise noted, there is strong evidence about the dose of therapy that should be offered, and we're able to make the recommendation that the cardiorespiratory training should be of high intensity, which is more than 70% heart rate max. Now, I know a lot of people find this rather alarming. I'm sure there are kind of gentler but just as accurate terms for it than this. And people kind of think that we're going to have people sweating blood and they're going to be made to exercise as if they're training for a marathon or something. That's really not the case. 70% of heart rate max, given that most patients are in their mid-70s or older, is actually quite low, and most people with stroke aren't terribly fit before they have their stroke, and they certainly they're not any fitter afterwards. And so again, many stroke patients can get to that 70% max just by walking. And so although it's there within the respiratory aerobic training scheme, the actual kind of the perception of the exercise that they're having isn't that high. And the essential thing about this exercise and the task-specific training is there needs to be a lot of, not a lot, but there needs to be quite, for a decent chunk of time, needs to be regularly, and it needs to continue for fairly prolonged period. In the UK, often people think of rehab stopping after 6 weeks or so, which isn't enough to have a sustained effect. And so we need to be looking at how people can be exercising in an adequate dose. And the important thing, as Louise said, is that is not to dabble. Don't dabble. Don't do little bits of lots of little things that are recommended. The main core of it is exercise and task-specific practice, and you need to be looking at how to organise things so people are getting a dose of that is effective. And if you're doing mixed training, as in mixed aerobic, strength training and functional training, something like circuit training, then that's a more moderate level of cardiorespiratory training, but you also actually need to look at the strength training. Think back to your physio, when you were in physio school, you will have all covered this. You know how to do this. For some people, it will have been a while ago, but this is all basic stuff that you covered in physio training. It's not rocket science. So you need to look at the actual resistance that people are getting in their strength training. And as I said, it needs to be regular, and it needs to be for a reasonably prolonged period. Next slide, please.
Sarah, I might just stop you there for a second and ask a couple of questions. Yeah. Louise is answering a couple separately, but somebody's wanting to know if somebody has a sitting balance problem, how long do you decide to go on treating that if, perhaps if the person's not changing? And I think that's a difficult question to answer. It's how long is a piece of string? There's so many variables.
Exactly.
That.
There isn't a set length of time. It all depends on the patient's goals, their preferences, the degree of impairment they have.
Yeah.
The thing is, there are people who don't have or have limited sitting balance. Is that obviously they're people with the more severe strokes. And the evidence on recovery from severe stroke is that it takes longer to start, and its improvement happens at a slower rate. And obviously, it tends to top out at a lower level than people with a milder stroke. So yeah, there isn't an answer. You know, it would be meaningless to say, oh, do 2 weeks, but don't do 2.5.
Yeah.
The issue is whether you're getting change, and you can get improvements in function without there being improvements in the impairment. So even if somebody's balance impairment isn't improving, you could be working on function, or as Louise alluded, you met the focus of the therapy may be on using aids and adaptations rather than looking at motor recovery. It may be about training carers how to look after somebody rather than focusing on the patient's actual motor recovery of motor impairments.
Yeah.
Was there another question?
Somebody who works in an early supported discharge service saying that it's very difficult to help people participate in 3 hours of therapy a day when they're early, in the first 6 to 8 weeks post-stroke. I mean, I find when we run workshops, people can manage 3 hours a day often, and it's a case of us trying to increase the intensity and get people used to that. Sure, there are some people who, have significant fatigue, and maybe in those cases you've got small blocks of time when the person's working on different aspects of their rehab. But that's, I think, why our guidelines in all countries are starting to get therapists to think much more about what we should be trying to expect in a typical day. And we really have a very low expectation generally.
Yes. I mean, an awful lot of this is tied up in the patient, in the therapist's confidence and know-how and the expectations that they have. So if somebody's not in hospital, yes, it can be more of a challenge, and it's a challenge that you need to look into how to rise to that challenge. In the in the principles of rehabilitation section of the guidelines, there is whole sections on self-management, on remote rehab, and on what I think they call it self-practice or something, but it's about independent practice. So it's about thinking more broadly about how you deliver therapy. And your job is actually to organize the patient and quite possibly their family in order for them to be as active as possible, rather than you standing over in one-to-one, or obviously there'll be some of this, but one-to-one therapy where you're directing what the patient's doing. It's a shift towards enabling the patient to do it themselves. And so this slide is very timely. As I said, you need to look at taking active steps to ensure that the patient knows what they're doing, how they're doing it, why they're doing it, how it will help, how to integrate it into other activities, how to make sure that the family and the other important people in the patient's lives have got buy-in as well, and to look at using social networks and social media. There's lots of activity platforms and things, using videos and phone calls to check in on people, that type of thing. There's a whole section on that in the guidelines, so I would recommend you have a look at that and maybe have a look at some of the evidence that's behind it as well. Okay, next slide. And so some of the other recommendations about exercise is, so the ones on walking, and this also applies for balance training as well, is focused on high intensity task specific practice, and that includes using treadmills with or without body weight support, or electromechanical gait trainers, which are the robotic gait trainers. And again, that needs to be at high intensity, and you can use the the inclination and the speed of the treadmill to enable people to walk at a fast enough rate to get their heart rates up, up to that sort of level. And it needs to be at a decent dose to be effective, just like exercise for anybody, in any setting and for any purpose. Exercise and task-specific practice just doesn't work if you don't do enough of it. So that doesn't mean to say that you wouldn't do any of the, if you like, traditional gait training and taking a motor retraining approach, but the strongest evidence is for using treadmills and gait trainers. But once you've got somebody able to put one foot in front of the other, then that needs to be translated into real world practice and real world training. So you also need to incorporate that into people practicing outside, managing curbs and rough terrain and dealing with crowds and changing direction, going fast enough to cross the road, dealing with busy environments and changing environments and that type of thing. Again, there's very strong evidence that that's necessary. There's recommendations for AFOs, and it should be a lightweight, flexible AFO in the first instance, or FES. So there's been several good quality meta-analyses that show that they're equally effective. But it needs to be, if you're going to use an AFO, use a good one, not some of the horrible ones that there are around. And again, in not letting the managers and commissioners off the hook, there needs to be space and there needs to be equipment to enable patients to be able to do this. But also because I know some people will be holding their hands up in horror going, we don't have any robotic gait trainers, we don't have any treadmills, and we can't possibly afford it. Well, hospital trusts can afford millions and millions of pounds for scanners and things. There is money around. You just have to persuade them that they need to. And I know it's not just, but you have to persuade them that it's a good way to spend their money on this type of equipment. But also there will be other services in the locality somewhere, other services that do have this equipment, whether it's cardiac rehab or pulmonary rehab services or other charity sectors that certainly in the UK, things like the Stroke Association run a lot of activity and exercise groups, or looking at health centres or gyms or leisure centres. They often have equipment that one could access if one, you have to go out and make those links. And certainly there's a lot to be gained by looking at how cardiac rehab operates, looking at the protocols and the know-how and the equipment that they've had, looking at seeing how you can collaborate with them in order to bring in this type of therapy. Next question, please. No, not next question. Next slide. Sorry. Looking at the upper limb recommendations. Again, it's for high intensity task-specific practice with trunk constraint for people who have limitations of their shoulder. If you restrain the trunk, then it helps to focus the movements that they're practicing onto the shoulder and elbow rather than the compensations. And that practice includes constraint-induced movement therapy. And also adjuncts. Now, adjuncts are, it's a rather strange term. I'm not quite sure why it became so popular, but they are additional interventions that you can use to enable people to exercise and to practice. These are not replacements for that practice. They're additional interventions that you can use to supplement the practice. And particularly for people who are more severely affected, it's using these types of adjuncts that can enable people to get up to those types of doses of therapy that we're talking about as a supplement, not a replacement to the exercise. So there's mirror therapy and mental imagery. For there's electrical stimulation for the shoulder subluxation and electrical stimulation, or preferably FES, for the wrist and finger extensors, and for the, as I said, for the lower limb as well. But there's a specific recommendation that you don't use electrical stimulation for spasticity, because it just doesn't work. There's also a more cautious recommendation about using transcutaneous, that's essentially TENS stimulation for to supply vagal nerve stimulation. I think that's a more emerging area, but the evidence that there is so far is very good. It does seem to work. And so next slide. Just to talk about the splinting, because I know you've got another lecture on that. And there's also part of the reason I didn't go into the Bobath thing in more detail is that, as Annie mentioned, there's a whole session on de-implementing Bobath, and I would thoroughly recommend that you go to that. And also the session on splinting. So we didn't specifically review splinting within these guidelines. Splinting is covered in the section on spasticity and contracture. And so there are some updated recommendations with regard to spasticity and electrical stimulation. But essentially, the evidence for splinting is pretty limited, and what evidence there is that it just doesn't seem to be effective. So you certainly shouldn't be offering it routinely. We did have a consensus level recommendation that for people who have troublesome spasticity, and it is a minority of people who have spasticity and a minority of people who have spasticity for whom it is actually troublesome. But for those people who have Botox, then you might consider using electrical stimulation after the injection to maintain range of movement or to give a stretch. And for if splinting isn't tolerated. So that's the type of setting where you might consider using splinting, or probably more effectively casting. So there is some suggesting that casting may have some effect, but using casting rather than splinting. But that's as far as we go with the splinting in the current guidelines. Next slide, that's the one. And this is my final slide. There are other new and updated sections which are, I think, really important and make really big changes. And as I said, I realise it's rather geeky, but it is worth having a really good look through the guidelines. So in the section on the principles of rehabilitation, which is at the start of the chapter, we cover rehabilitation potential, we cover intensity of therapy, we cover some of those other ways of delivering therapy outside the one-to-one one-to-one formal therapy sessions, if you like. There's a whole new section on fatigue that Frederica van Week led, which is really good actually and very helpful. There's, as Louise I identified, the section on vision has been updated and expanded. There's recommendations for staffing level. There's a whole new, well, it's not completely new, but updated and expanded section on vocational rehab. Psychological care includes cognitive screening and assessment, and also mood. And there's a lot of work being looking at swallowing and hydration and communication as well. So yes, it's a bit of bedtime reading for you. And I think that's my last slide, isn't it? Yes. So I'm happy to take any questions that have come in.
Thanks, Sarah. There are a couple of questions. I think, Louise, you wanted to make a comment about the 3 hours first before we go on to the other 2 questions.
Yes, if that's okay. So just in response to our colleague that commented around ESD and people not being ready, I think whilst we haven't seen practice change across the pathways, I think that can be tricky. So I think certainly patients that are coming through, people with stroke that are coming through that haven't had that sort of approach in their acute stay, or even perhaps in their inpatient rehabilitation stay, we can't expect people who haven't had any sort of intensity given, we're talking about 23 minutes on average still across the UK, to suddenly come out to ESD and understand and tolerate 3 hours. But hopefully, as we've developed that intensity approach right from early, as soon as somebody can tolerate and they understand and buy in to their role in the rehabilitation, that people will then come through to ESD slightly less deconditioned and more able to tolerate. So I think we're probably still in that changeover period where we've not nailed it really in inpatient care either. And that's a really hard ask then for you to try and turn that tide in ESD. That was just the comment I wanted to add. Thank you.
Yeah, I think
absolutely. It's getting buy-in from the patients and the family is really important. A lot of stroke survivors will be worried about the prospect of exercising because they're terrified of having another stroke, and so are their family. And they worry if they do anything stressful, even if it's just exercise stress, then that could be harmful. So they need reassurance, they need encouragement, they need education in order to understand why they're being asked to do this, and that it's safe. It is very safe. And I know a lot of therapists worry about the high intensity therapy as well. But this has been used for cardiac rehab for decades. It is very safe. Make friends with your cardiac rehab team and find out the protocols they've got, the approaches that they use, and the screening that they use. There was something else I was going to say about that. That's it. With all these recommendations, when you look in the guidelines, you will see this, that you're not going to throw somebody onto a treadmill if they really don't want to do it. They have to consent to it. And the therapy that you deliver will all depend on the patient's goals and their preferences and their priorities. So, we are not saying that everybody does exactly the same and they must all do this. Obviously, you have to individualize what you are doing to the person. This isn't a recipe and a blanket statement of what you must do for everybody. Sorry, did we have some other questions?
I was just going to comment that if you work in an inpatient setting, I think it's part of your responsibility to teach people and their families about the expectations in rehabilitation. It's going to be a long road for lots of people. And if they leave hospital and haven't learned that that's part of their role, and they can make an active choice about not participating in rehab, but I think that's really important for the inpatient rehab therapist.
Absolutely, yeah.
Louise, you wanted to add something there?
I think just to add to that comment, Annie, I think, and I know I've mentioned it already, understanding somebody's levels of activation, I think is really important as well, and something that we probably don't do enough. There needs to be more targeted work, and there is some evidence around what that looks like, but around readiness for this sort of taking charge of your own health and your own rehabilitation. We need our psychology colleagues, and we need to be looking at that sort of acceptance and readiness and that motivation for health change as well. That's a really important part of the education piece and preparing somebody to do those sorts of levels of intensity. Thanks.
Yeah, I think it's easy to forget when you're working in with stroke survivors all the time, that people, a stroke is a major life-changing event. So these folk have, they're going through a major life event. They're having to cope with all sorts of stuff going on. It may be that they're depressed, that they're frightened, that they're very anxious, that they're apathetic, that they can't face the thought of doing X or Y at some point. But that rehab is not a one-off offer. So if somebody can't face something at one point, that doesn't mean to say that they never will. And I think one of the really important things that we've highlighted in the guidelines is that there should be access routes back into therapy and rehabilitation. It's, you know, so and you do get, you know, people certainly in the early stages after stroke, all they want to do is to stick their head under a pillow and wait for it to go away. And it's about you know, finding ways to, and that's part of our job, is to, you know, is to work with that individual and everything that they're going on with, to find ways in which we can enable them to do as much as they can manage and cope with.
I might just get you to answer the last question before we wrap up, and that's about any recommendations on pusher behaviour management for people who've got sitting balance and are pushing themselves.
Right. No, there isn't in the guidelines. There's, I mean, essentially the recommendations for sitting balance is that, well, for all balance, is that people should have task-specific practice and practice sitting balance. Essentially for pusher syndrome, what you need to do is to give people sensory cues. Yeah, so people who have pusher syndrome tend to be this, you know, severe end of stroke, and they've lost their perception of where vertical is, and so they're not quite sure where upright is, and so you need to give them sensory cues in order to help them re-establish where their upright is. The classic is to sit somebody next to the wall and tell them to shift themselves so that they're leaning against the wall. Now, very often a lot of sitting balance is actually about weakness in the hip rather than the trunk. And often these people may have a complete paralysis of their lower limb. But you can be telling people as far as possible to try to push with their affected leg, their weak leg, so that they're pushing themselves upright as far as they're able, and they're bringing themselves back so they're leaning against the wall or they're touching the wall. You can use a mirror with a midline down the middle and put a button or something on the patient's. Don't put a sticker on their forehead. I did see somebody do that once, but some visual cue so that the patient then kind of lines themselves up with the midline. And so you can use visual cues, sensory cues, and get them thinking about, okay, this is actually upright. This is what it feels. It may not feel like it's upright to them. They may feel that they're leaning the other way, but get them practicing on that sort of level.
But I should add, Sarah, that's consensus or expert opinion. It's not based, there's very few studies, which is why it's not in the guidelines. There's same with ataxia. There's very little research on interventions for people with ataxia.
But there is a very good lecture that Carl does on the StrokeEd resources. There's a lecture that Carl does about balance and the trunk, and he's got a rather fab video of somebody who has pusher behaviour, and he gets them sitting up straight and practicing. So have a look at that and be amazed and impressed, because it's very good.
I'm going to bring this to a close now, because we're a bit over our hour, and I think it's probably time to end and say thanks very much to both of you for your time and for all the good questions. Just a reminder to anybody who's still online, we're not providing any handouts or certificates for the free lecture series. What you get is what you get, and we hope that you find it helpful given all the time that people have spent preparing the presentations. And we're delighted to see lots of people joining us. So yeah, thank you very much, Louise and Sarah and everybody else, and good night or good day.
Good morning, it is here.
Good morning.
It's been a pleasure.